My talk is going to discuss the path that we took to obtain and obtain comprehensive stroke certification. A unique feature of my hospital is that we do not have neurology residents and fellows, and it turns out they are a key part of multiple disciplines involved in treating acute stroke. And there are greater challenges, I think, in large centers that do not have neurology residents. So the purpose of my talk was to try to outline that in some way. Okay. Now, one of the things that I acknowledge is that my medical center, Bident Medical Center, developed an idea, a focus, a stroke program, and vision. And I think this is very important to have in mind when you're developing a comprehensive stroke care center. So the mission, as you can see here, is to provide the highest and standard of care for treatment of stroke. And it goes beyond it has to include not only acute stroke care, which is what I'm focused on with this talk, but also the entire stroke care continuum is very important to emphasize, which in particular focuses on primary prevention. You know, stroke is a great example of an ounce of prevention is worth a pound of cure or treatment. If we need to focus on ways of treating vascular disease risk factors as a way of preventing stroke. And then the vision was to become a model, particularly, again, if you want to say a medical center that does not have neurology, first-line neurology residents and fellows available. Now, to discuss or even bring up stroke as a topic, I think it's very important to understand that where I live and work is part of the stroke belt that I think everyone is aware of or has heard about that involves the southeast. These stats are up here. What I like to say is we're not only part of the stroke belt, but where I am in Greenville, North Carolina, could almost be the buckle on the belt that involves the North Carolina Piedmont coastal area going down to South Carolina and even into Georgia. One could even make the argument that we're the rhinestone on the buckle because we see that much stroke where I am. These are just some other basic statistics to throw out there that indicates that stroke is higher in the state of North Carolina and in particular in the eastern part of the state where I am, and that a third of stroke hospitalizations occur in younger individuals. Another important thing that my talk doesn't touch on, but I want to at least acknowledge, is there are disparities based on ethnicity in stroke also that are important to keep in mind. Stroke is more common in American Indians and African Americans, and stroke affects those groups at a younger age. The other thing to also keep in mind with stroke is that even with our present treatments, approximately 30% of stroke survivors may have permanent disability. Another 20% may require be institutionalized for a period of time as a result of their stroke. The other thing my talk is not going to go over is the cost of stroke. And I'll just throw out one statistic, which is that one year of stroke care can cost over $50,000. So you can start multiplying that by the number of strokes. Okay, one important thing is to develop this type of a program requires multiple disciplines to be involved. That's probably the key thing, and I have the perspective of being at the hospital where I've been, where since 2000 and seeing stroke care evolve over that period of time. So I'm not going to go through all of these different disciplines that are involved, but that you need to have to produce a comprehensive stroke care, but this is just a listing to give you some idea of the number of different disciplines, I guess would be the best way of putting it, that need to be involved. And again, my talk is focused on acute care, initial care, but of course, a comprehensive stroke program has to involve taking care of patients, after they've had their stroke, which of course includes physical rehabilitation and management. So I'm going to start presenting then some of the statistics that indicate what we had to do to achieve this comprehensive stroke care certification at my medical center, Vidant Medical Center. So this is just to give you an initial idea of the number of stroke volumes that we see, approximately 1,000 ischemic strokes per year. This number turns out to be pretty accurate because it's usually said that there are about 80% of acute strokes are ischemic and about 20% are hemorrhages, intracranial hemorrhages in particular. Now, if we look at what had to occur over time as we developed our comprehensive stroke care pattern is that you'll see the number of acute strokes treated went up significantly. You see these numbers from calendar year 2016 to 2017. And this includes treatment of stroke in the emergency room and, of course, stroke transfers and transfers from outside facilities. One very important feature that occurred that when it would have been in March of 2016, we started to be able to offer mechanical thrombectomy to patients. And that was the initial time that was made available, and that significantly increased over time as we increased the number of endovascular surgeons, so that eventually in August of 2016, 24/7 coverage of mechanical thrombectomy became available. So you can see how dramatically the number of endovascular procedures goes up over these 2 years. Then if you, again, to get an idea of, at looking at the calendar years from 16 to 18 and the total number of strokes that are being treated, again, that has to do with the fact that the time frame for treatment for this mechanical thrombectomy went out as far as 6 hours, and in fact it's going to go out beyond that. Some centers are already doing that. And then this is just a way of looking at the increase over time of the use of alteplase TPA, the tissue plasminogen activator, which is the acute thrombotic that's used in the first 3 to 4.5 hours for acute stroke management. And again, this is probably the key stat that reflects our ability to treat acute stroke with the most up-to-date treatment, which involves potential endovascular mechanical thrombectomy. And you can see how these numbers have dramatically increased with beginning in 2016 when we had our first endovascular neurosurgeon, and then later in the year a second one that again allowed us to provide 24/7 coverage of this. And over time, you can see what has happened with the number of acute stroke transfers. Vidant Medical Center is has multiple other, is a true center that has multiple sister hospitals around it, but our stroke coverage area is from basically east of Interstate 95 up to the Virginia border, and then as far south as Wilmington. So we're getting referrals from all all surrounding hospitals in the area. And you can see the number of people that, again, received, just gives you an idea from June, just in 1 year's time, most recently, how these numbers have escalated. So this is, I just throw this, or this is, the idea of this is to show a timeline as to how this stroke care program developed. And this is just a timeline of events. As I said, it was in March of 2016 that we had an initial endovascular treatment program. But you can see over time, these other features had to occur to provide the most up-to-date, most acute and timely stroke treatment. I mean, one thing I haven't said is time is brain is a wonderful term that we use, and everything is focused on treating an acute stroke patient as quickly as possible to provide the best outcome. This again just continues to summarize things that needed to be done. For instance, something you wouldn't think about, but getting somebody directly from the emergency room into the CT scanner. That has to occur rapidly, as quickly as possible. You can't be hung up. How about something as simple as, I don't see it there, but even weighing patients, that had to be, that used to be a hang-up. Because the TPA is administered on a weight basis. Now, the newest features, or the latest things to come along here, oops, let me go back, are this, in June of this year, there was the installation of this rapid software for what's called CT perfusion, which is a necessary, something that's necessary to evaluate patients who are beyond who may come in 6 hours after the onset of their stroke symptoms. Now, one of the, okay, let me go back. Oh, okay. Yeah. One of the features then that we learned over time is that our neurology group could not provide rapidly enough acute care, and so eventually over time a model became available to, through the hospital, hiring neurohospitalists to provide stroke care. Again, here's the in-ground scale for weighing, so these are some of the things, some things that you wouldn't even think about but are needed to improve the timeliness of treatment. This, over time, what needed to be done was a series of meetings to involve all the disciplines that would be involved with acute stroke. And this turns out to be, starting with the emergency room, critical care, neurology seeing patients, and then potentially the endovascular treatment with endovascular neurosurgeons. So this slide just outlines, some of all the acute care stroke management that is needed. Again, we had to develop algorithms that would involve acute care coming just to our emergency room, but as well for all of these regional acute care transfer patients. Now, a lot of these patients have already received TPA, the clot-busting drug, and so by the time they come, the management involves their evaluation to see if they're a candidate for the endovascular thrombectomy. So we had to develop this type of an algorithm so that people would be, so that patients who arrived, and the decision was to have these patients go to our emergency room, for instance, instead of going to the ICU, because the emergency room is where you can get an acute CAT scan or CTA that's needed, or now potentially CT perfusion, and then the vascular interventional radiology suite is very near the emergency room also, so it made the most sense to have these patients come directly to our emergency room. So since February of 2018 is where we started the model that involves a stroke neurohospitalist basically available to cover acute stroke. As of August of this year, we now have two stroke hospitalists, we have stroke hospitalists, neurohospitalists who are working doing 12-hour shifts 7 days a week. And then there are two of them obviously covering the full week. And so and then the other feature is that the endovascular treatment, as I mentioned, we now have, we had to have two endovascular neurosurgeons to provide 24/7 acute stroke management, and there actually is going to be a third endovascular neurologist who will be starting next summer. And so in Eastern North Carolina, we are now providing this type of 24/7 care full-time. I mentioned already the installation of this software for the CT perfusion, and then as of November, which is very soon, next month, the protocol will be expanded to patients having acute symptoms up to 24 hours. So this is from the dawn, what's called the dawn trial or wake-up stroke, where you can literally, before you were not a candidate for acute treatment if you woke up and had gone to bed the night before. Now you can indeed have awakened or been up to 24 hours out since you were last normal. Okay, these are just some other features that I know I'm running over on my time, and I certainly want to answer questions also. But so I'll kind of briefly say that these are again emphasized features that were needed with our regional transfers. And okay, and then as I said, the current protocol is 6 hours, but we will be going out to 24 hours. Okay, and I think this is my final slide, which is there are a number of metrics or timelines that you can use for acute stroke management. I don't have slides on this available, but they involve the amount of time it takes to get from arrival in the emergency room into the CT scanner, the amount of time it takes to get TPA, and I didn't mention one feature that had to be instituted was to be able to give patients the clot-busting drug in the CAT scan area instead of back in the emergency room, for instance. So all of this led to our hospital becoming Advanced Comprehensive Stroke Care certified in July of this year. We are actually the 9th facility in the state of North Carolina and the 171st in the United States. And I think I've run over and I apologize.